Good evening, everybody. Welcome to this evening episode of Pursue, and we have Pursue 9C Cytopathology, and we are streaming live from Kuwait City via Kolkata. And today we have a very special person, Dr. MALLIK, who's an MD from PGI Chandigarh, an expert in fine needle aspiration cytology as well as conventional cytology, and he's a consultant cytopathologist from Mubarak Al Kabeer Hospital, Kuwait, with more than 22 years of experience in conventional as well as special cytopathology. And today he shall be talking on something which is very important and it has been changing again and again. He's talking about thyroid FNACs, FNAC of Thyroid Lesions, conventional and complicated. He's an expert and he will give us an expert view. He will try to teach us how to approach thyroid FNA and how to go about it, what are the Bethesda criteria, and how each and every aspect has to be looked in. So this is a very good talk for everybody to understand thyroid FNAC and various aspects of thyroid cytopathology. Before I ask Dr. Mallik to take over, let me request all of you, please keep your mic muted, your camera off, and please don't share your screen. And with this, let me request our special presenter, Dr. Mallik, sir, please take over and please share your screen.
Thank you, Nadeem. If you could just guide me through the process once again that you've done.
On the present now, on the right side of your computer screen, there's present now, just press on that.
Yeah.
And then you press your entire screen.
Yep.
Then a window will come up, press on the center of the window and share.
Yes.
And your screen will be shared. Yeah, I can see your screen coming. Now, just go to the bottom of your taskbar and share your PowerPoint, please. Right, please make it full screen. Yeah, there we can see everything. And please click on that hide pop-up so that that pop-up just goes away. You can change your pointer if you feel like. It's okay if it's like that. No, it's perfectly fine.
Okay, I think I'll do the pointer like that.
Yeah, please start. So, thank you so much. Take care.
Thank you as usual, Nadeem. And good evening, everybody.
This is done.
So the topic of today's webinar is fine needle aspiration cytology of the thyroid. This is the first of the two webinars that I intend to do. And in this one, I'm going to talk about the basic principles and technique of fine needle aspiration cytology of the thyroid. And then we'll move on into the Bethesda system of reporting. And for this particular webinar, I shall be dealing with Bethesda's 1, 2, 3, and actually I'll add one more, 4. So this particular title is not correct. So I'll be doing Bethesda 1 to Bethesda 4. So here is the first slide. And I decided to start with this one because this really is the key point. So fine needle aspiration cytology is the procedure of choice in the evaluation of thyroid nodules when clinically indicated. Now, this is according to the American Thyroid Association Management Guidelines for adult patients with thyroid nodules and differentiated thyroid cancer, published in 2015. And this is a very strong recommendation, which is based on a high quality evidence. So as far as this webinar is concerned, this is going to be the general outline. I shall be dealing with Bethesda's 1 to 4. But before that, I'll be dealing with a few other issues. And in the next webinar, which is going to be coming up sometime soon, I hope, and you are going to be notified about those, about that webinar. In that I shall be dealing with Bethesda's categories 5, 6, some diagnostic algorithms, the role of immunohistochemistry, some other ancillary tests, and other practice points. So, some of the slides, some of you might have seen before in my previous webinar on general FNAC. So, the thyroid FNACs follow the similar principles. So, there can be two major types of FNA, palpation and ultrasound guided. It is extremely important to get a good quality aspirate. It can be done either with the help of a syringe or without a syringe, which is called the aspiration technique or the sampling technique. The sampling technique is preferred by a number of cytologists, including me, because it ensures that the sample is not too hemorrhagic. And this is just a picture of a procedure of ultrasound guided fine needle aspiration cytology with the needle inside a particular nodule in the thyroid gland. The preparations of smears is extremely important. And personally, I like to do palpation guided FNAs because, wherever possible, because I can make the smears. I also make the smears when I go for rapid on-site evaluation for ultrasound guided FNAs. But I feel that when the FNA is done by the radiologists tend to keep the needle a little bit longer than what I would love to. And that brings in a little bit of blood. So maybe it's my experience or maybe it's the general experience. FNAs which are done in the radiology departments appear to have a little bit more amount of blood than what I would like to see. But maybe other people have different experience as far as this is concerned. The needles are used at 22G to 25G needles. You can make around 2 to 3 punctures per nodule. 3 is about the maximum. We routinely use ethyl chloride spray. All the smears are fixed in 95% alcohol or they are fixed using air drying. Do Papnicolau and MGG in all our cases. We keep some needle rinses in case for other ancillary studies when they were required, and cyst fluids are prepared using cytospin. So I'm just going to rush through these initial slides. The history taking is of crucial importance, and these are some of the aspects as far as the history is concerned. Apart from the age and sex, we should take good note of the location and the size of the nodule. You should ask the patient about any history of rapid growth of the nodule. If there is any history of hoarseness, the patient should be examined for lymphadenopathy. The mass, if you are palpating the mass, if it is palpable, you should find out if you see if it is fixed to the surrounding tissues. There should be a history of prior surgery should be taken. If there is any, very important to know if there is a history of radiation to the head and neck region for obvious reasons, or if there is a history of total body radiation for bone marrow transplants. A familial history of thyroid carcinoma with these syndromes of Cowden, FAP, Carney's, if available in your history. I mean, if the clinician is good enough to tell you, or you can see some of the symptoms and signs related to them. Should have the results of the thyroid functions tests and thyroid radionuclide scan. We shall be dealing and discussing this in more greater detail later on. And of course, most importantly, the ultrasound appearance of the nodule. Let's begin a little bit with some of the basic safety issues. The complications related to thyroid FNA, the most common is not exactly a complication, but it's just an issue, pain and discomfort. Most people would complain of a little bit of pain and discomfort. The important things to remember are things like bleeding, which are mostly small, 5 to 25% according to most series. Those leading to life-threatening and airways obstructions are extremely rare, and so are vasovagal attacks, tracheal puncture, post-aspiration thyrotoxicosis, and needle tract seedings. And if any one of you would like to find out more about these, there are some links at the bottom of the slide. Now, about patients who are at greater risk of bleeding, we should keep in mind that if patient is on aspirin or Plavix, we should discontinue it for 5 days. People who have some kind of bleeding disorders or are on warfarin, their INR should be ideally brought down below 1.2. The referring clinician should be aware of the protocols that you are following, and in case you need to stop the medication, you should send the patient back to the clinician, and he should be the one to do it, because there could be other issues which are associated with the medications, and you would not like to just ask him to stop on your own. Now, when do you aspirate thyroid nodules? This is a very, very important question. So we just can't go on and we just can't put a needle into every thyroid nodule. So the decision, and this is very important, the decision to aspirate or not to aspirate thyroid nodule depends on a lot of variables, and it depends on the presence or absence of a combination of deciding factors, which comprises most importantly of TSH levels, as we are going to see very soon, radionuclide scan results, size, and other sonographic features associated with the nodules. It's very important. So what exactly is a thyroid nodule? It sounds very easy, but it might be a little bit tricky. especially in the context of fine needle aspiration cytology. So, as simple as it might sound, a thyroid nodule is a lesion within the thyroid which is palpably and or radiologically distinct from its surroundings. The prevalence of palpable thyroid nodules, estimated in approximately 5% in women and 1% in men living in iodine sufficient parts of the world, according to some of the big studies. There is one study which I am aware of from India, from the southern part of the country, where the incidence of thyroid nodule in the general population was found to be around 12%, according to a study by Menon et al., published in 2009. But these are the ones on top. These are the two big studies, which uses a lot of data from patients across the world, and very long. So I think one of them is around a 15-year-long study. So the next issue is, what about nodules? So if you feel a nodule and seeing the nodule on ultrasound, they're not really the same thing because of these reasons. First of all, quite surprising, 16% of patients with one palpable thyroid nodule will have none on ultrasound evaluation. So you may be able to, out of every 100 patients, there will be 16 patients where you think there is a nodule, put the patient under ultrasound evaluation and there is no nodule. And in about 15% of the cases, okay, there is even if you feel one nodule, there will be a second nodule at least, which is greater than 1 centimeter on the ultrasound. So if you feel a nodule, it doesn't mean that there is no other nodule, even if that nodule is a real nodule. And therefore, a thyroid ultrasound, which includes evaluation of the cervical lymph nodes, is mandatory in all patients with known or suspected thyroid nodules. So that is extremely important. Before you do an FNA, there should be a thyroid ultrasound. So why is an ultrasound mandatory? An ultrasound is mandatory because it answers the following questions. First of all, as I've said in the previous slide, it tells you, is this truly a nodule that corresponds to an identified abnormality? It tells you about the size of the nodule. It tells you about the nodule's pattern through its ultrasound imaging characteristics. Is there a suspicious lymph node somewhere? Is the nodule greater than 50% cystic? So primarily whether it is mostly cystic, mostly solid. And is the nodule located in the posterior part of the thyroid gland? Now, the last two features, that whether the nodule is 50% cystic or not, or whether it's located in the posterior part of the thyroid gland or not, is very important. Why is it important? Because under these circumstances, it has been seen the accuracy of FNA starts going down. And these, once again, are according to the recommendations of the 2015 American Thyroid Association Management Guidelines, which is followed by most of the clinicians across the world. So, when do you go for an ultrasound guided FNAC? So, the first one, you go for an ultrasound guided FNAC when the nodules are not palpable, and most of them are posteriorly located nodules. So, primarily, any nodule which is not palpable, fulfills other criteria that we are going to see very soon, should go under ultrasound guided FNA. Nodules with a significant cystic component. So, but there is a kind of a discord in this, like according to some studies, should be around 25 or more than 25%, you should go for ultrasound guided FNA. Some say that if it is more than 50%, you go for ultrasound guided FNA. I think more than 50% is a more reasonable number. The palpation guided FNA has rendered a non-diagnostic result. So for some, you have gone for a palpation guided FNA, the results are non-diagnostic. Obviously, the next one you should try is an ultrasound guided FNA. And the fourth point is very important. In children, ideally, all thyroid nodules should be aspirated under ultrasound guidance. And there is a separate slide which I prepared for FNA, thyroid FNAs in children. You are going to see that again a little bit later. So when exactly do you do a palpation guided FNA? So according to the recommendations, if an ultrasound shows a predominantly solid component corresponding to one palpable nodule, a palpation guided FNA may be considered. However, this all depends on your practicing situations, in the environment where you're practicing, how much you depend on your radiologists, how good your radiologists are, because we have to remember that ultrasound is an extremely operator dependent technique. So it may differ. These are some of the recommendations of the American Thyroid Association. However, other places may have different kind of practices. For example, in India, there is a study which was published in the Journal of Pathology and Translational Medicine in 2017 by Agrawal and Jain, and it was found that the palpation-guided FNA is far more common than US-guided FNA of the thyroid, possibly because it's more cost-effective. So US-guided FNAC was mainly used for small and deep-seated lesions, cystic lesions, and previously non-diagnostic category. But I think that the criteria of going in for ultrasound-guided FNA might be a little bit less stringent because cost is a very important factor. Right. Now, some key facts about the thyroid nodules. About 5% of thyroid nodules are malignant. It may be about as high as 7 to 15%, depending upon a person's age, sex, radiation exposure, family history, etc. Ultrasound evaluations are highly accurate with very high negative predictive values to considerably reduce the necessity of a FNAC in the majority of the cases which are considered benign. One system of classifying thyroid nodules, there are different systems, but one of the systems which has come up and become very popular in recent years is based on the sonographic finding. It's called the TIRADS system, and there are actually 3 different TIRADS systems. So TIRADS stands for Thyroid Imaging Reporting and Data Systems, and there are at least 3 of them that I am aware of. The most popular is the ACR TIRADS in the United States and other parts of the world, possibly outside Europe, under the American College of Radiology. Then there is the EU TIRADS from the European Thyroid Association, and there is also a Korean Society of Thyroid Radiology TIRADS called KTIRADS. So what about TIRADS and malignancy risk? So actually, we say 5, but there are actually 6 TIRADS. Now this might be a bit confusing. So TIRADS 6 is not used by the radiologist for giving a diagnosis. The TIRADS 6 is a phrase or a term which is used for a thyroid malignancy which has been proven by biopsy. So we take this one out. TIRADS 1, of course, is an absolutely normal thyroid gland. So we are primarily concerned with TIRADS 2 to TIRADS 5. TIRADS 4 has got other subcategories. And based on this, there are different risks of malignancies. And the risks of malignancies are as follows. If it's TIRADS 2, the risk of malignancy is, if somebody is called TIRADS 2, so about, if you call 1,000 cases TIRADS 2, only about 9 of them are actually going to turn out to be malignant. So pretty low number, 2.9% malignancy in TIRADS 3. It keeps going up in TIRADS 4, and almost 86% malignant in TIRADS 5, according to articles which have been published recently, one by Mendes et al. This is the data from that study. Very similar kind of results we have be seen in a study by Chandramohan et al. Which is from Indian patients, published in the Indian Journal of Radiology, and one study from Egypt. And there are many other studies which shows that TIRADS is a pretty accurate system in evaluating lesion and at least saying that these are benign and we do not need to go ahead with FNAC in some of those cases, but there are other considerations. So what is the approach to thyroid nodules in adult populations? So the eligibility of thyroid nodules for FNAC using ACR TIRADS is as follows. So there is a nodule in the thyroid. The first evaluation should be a TSH. It's extremely important. If the TSH is low, then you go ahead and do a radionuclide scan. Okay, so it's a hyperthyroid radionuclide scan. On radionuclide scan, if you see that this is a hyperfunctioning nodule, there is no need to do an FNA. So if a patient has a low TSH, don't go for FNA. If it is found that it's a hyper-isofunctional nodule, then you go for the ultrasound. If the TSH is normal or high, the next test is ultrasound. And on ultrasound, there are various features which are assessed, and this is something which is dealt with by the radiologist or the ultrasonographer. They look at some of these features and they give this lesion a TIRADS score. Now, if it is TIRADS 1 is actually normal, so of course no FNA is required. If it is TIRADS 2, no FNA is required. FNA is required in TIRADS 3, TIRADS 4, or TIRADS 5 only if the size criteria are met. So these are the size criteria which are considered. So in TIRADS 3, FNA is done only if it is more than 2.5 centimeters. In TIRADS 4, if it is more than 1.5. In TIRADS 5, it is more than 1. Otherwise, you follow up, and these are the follow-up period which are recommended. However, depending on the kind of practice, depending on how much trust you have on the ultrasonographer, on the radiologist, the clinician may take different approach, and you may be getting patients. And I'm sure we do a lot of patients who are TIRADS 3, which are actually less than 2.5 centimeters. So I have seen that not always only this particular features are taken into considerations, and the clinician, of course, takes a clinical judgment based on a lot of other features, and you are going to definitely find FNAs. You're getting FNAs in lesions which possibly do not fulfill that site criteria, maybe smaller lesions than that. Right. So what about FNAs in diffuse thyroid lesions? Now, I can tell you one thing. I am seeing far lesser number of cases of diffuse thyroid lesions created by lymphocytic thyroiditis which come for FNA. Most of the cases of diffuse thyroid lesions would not require an FNA. However, one needs to remember that in certain situations when a lesion is producing obstructive symptoms, the patient has to go for surgery, right? They can come for FNA. You have to also remember the possibilities of diffuse malignancies like anaplastic thyroid carcinomas, where you take the radiological picture into consideration. Okay, and as I've said, benign conditions where obstructive symptoms are present, you may still have requests for FNAC of such lesion. In children also, the issues could be a little bit different because diffuse lesion in children are aspirated far more frequent than what you are going to do in adults. So, what about thyroid nodules in children and adolescents? Now, as far as the American College of Radiology recommendations are concerned, children and an adolescent, this basically refers to people under the age of 18 years. The management protocols are different. Why are the management protocols different? Because of this reason, it's very important. Thyroid nodules are less common in children. However, in children, the risk of malignancy is higher as compared to adults, according to most series. Next, papillary thyroid carcinomas in children have a higher incidence of extrathyroid involvement. They have a higher incidence of lymph node metastasis and pulmonary metastasis. However, the good news is that the children are less likely to die of disease in spite of extensive disease. And of course, there are differences in the genetic makeup of the disease, and I'm not going to go into the details of this in this particular webinar. So, what about FNAC of thyroid nodules in children? How is it different than that in adults? How are the recommendations different? The evaluation and treatment of thyroid nodules in children should be the same as in adults with the following exceptions. So let's look at the exceptions. So when you are deciding on whether to go ahead and do an FNA in a child, in this particular age group, children and adolescents, the US characteristics and clinical context should be used rather than the size alone to identify the nodules that warrant FNA. So that size cutoff points, which I showed you in the previous slides for adults, you need to just be more relaxed, and you have to take into consideration the US characteristics and clinical context. All, according to the recommendations, all FNA in children should be ideally performed under ultrasound guidance. That is the recommendation, but I don't know whether we always follow that, because I do a lot of FNAs in palpable nodules in this particular age group without any ultrasound guidance. A preoperative FNA of now this is very important. If it is a hyperfunctioning nodules in this particular age group, you really do not need to go for any ultrasound or an FNA. If it is a hyperfunctioning nodule, the lesion is goes straight to surgery and the lesion is removed. A diffusely infiltrative form of PTC may occur in children and should be considered in any clinically in a clinically suspicious gland. Most of the time, you tend to favor surgery like lobectomy or isthmusectomy over repeat FNA for nodules with indeterminate cytology. So if it is an indeterminate cytology in an adult, you might like to wait on for a while, but clinicians tend to subject these to surgery far more frequently than what, or far readily than what you would have done in case of adults. Now, coming to the main part of the discussion, reporting fine needle aspiration cytology specimen. And the main framework of reporting, which has been used by most of the cytologists across the world, is the Bethesda system for reporting thyroid cytopathology. And this is now the second edition, which has come up. And the main mission statement, as far as the Bethesda system is concerned, is as follows. Now, from its very inception, I'm just going to read this to verbatim. The Bethesda system for reporting thyroid cytopathology, or TBSRTC, it established a uniformed, tiered reporting system for thyroid FNA specimen. Using this system, the cytopathologist can communicate thyroid FNA interpretation to the referring physician in terms that are succinct, unambiguous, and clinically useful. As if I have to choose two words, I'm going to choose two. One is communication and one is clinically useful. So these are the two major aims of the Bethesda system. Has there been any changes between the first and second editions of the Bethesda? I think this slide at this point is a little bit premature, but I'm just going to put it over here just for the records. The risk of malignancy have been recalculated in Bethesda 2. When you compare with Bethesda 1, you are going to see that. The risk of malignancy has been shown in two ways related to the NIFTP. Okay, so the non-invasive follicular tumor with papillary-like nuclear features. The usual management of AUS and follicular neoplasms now incorporates the option of molecular testing. We are going to see that. The definition and diagnostic criteria of follicular neoplasm have been revised in the line of NIFTP. Cases that demonstrate mild nuclear changes associated with PTC are now included in FN. The definition and diagnostic criteria of papillary thyroid carcinoma subset of malignant category have been modified to suggest limiting uses to cases with classical. So you use the word papillary thyroid carcinoma when you have classical features. And of course, the facts about putting optional educational notes, both related to the follicular variant of papillary carcinoma and the non-invasive follicular tumor papillary-like nuclear features. We'll see more of those in the relevant section, but this is about the list. Now, this is an extremely important slide. So these are the categories. Category 1, I should have actually put the Roman numerals here, but this corresponds to 1, 2, 3, 4, 5, and 6. 1 is non-diagnostic, 2 stands for benign, 3 stands for atypia of undetermined significance or follicular lesions of undetermined significance, 4 is follicular neoplasm or suspicious for a follicular neoplasm, 5 is suspicious for malignancy, and 6 is malignant. Now, as you can see over here, the malignancy rates are different. So as far as the malignancy rates are concerned, as you can see that the malignancy rates go up as you go from non-diagnostic right up to malignant. Importantly, that in the non-diagnostic category, there is a 5 to 10% malignancy, and then it keeps going up. Now, there are two different columns. This column calculates the rate of finding how many of them turn out to be malignant on follow-up when NIFTP is not considered a carcinoma. Wherever here, it is considered the risk of malignancy based on when NIFTP is considered to be a carcinoma. So this is the difference between these two columns, and you see the differences here, but not too much of a difference actually. But this is one of the revisions. The last column is the most important column. So what is the usual management? If the patient has a non-diagnostic or unsatisfactory repeat FNA, and I'll be dealing with them a little bit later, benign clinical and ultrasound follow-up. For atypia of undetermined significance or follicular lesions of undetermined significance, it is repeat FNA or molecular testing, and even you may consider lobectomy. For follicular lesions of undetermined significance, you go straight for molecular testing or lobectomy. There is no place for a repeat FNA here. For suspicious for malignancy and malignant, you go for a near total thyroidectomy or lobectomy, in both the cases. One important point about the nomenclature. It is recommended that every laboratory choose one of the two available phrases when you are dealing with Bethesda category 3 or 4. So either you use the term Atypia of undetermined significance in your reports and do that in all your reports of this category, or you use the term follicular lesion of undetermined significance for your reports and use it in all the categories. I personally like to use the term Atypia of undetermined significance because I think it's a more inclusive term. Similarly, for follicular neoplasms or suspicious for follicular neoplasms, it is recommended that you either choose to use follicular neoplasms for all such reports or suspicious for follicular neoplasms of all such reports. Choose one and don't use them alternatively in different reports. So that is one of the suggestions by Bethesda. So the Bethesda system for thyroid cytopathology reporting have got these general diagnostic categories which you have talked about, and under each one of them there are subcategories, and we shall be dealing with those subcategories in the subsequent slides, and let us see how they turn out. So first of all, the non-diagnostic or unsatisfactory category. So what are the situations where a specimen can be non-diagnostic or unsatisfactory? It could be most commonly, as we see, in situations where the aspirated material is only cyst fluid. It could also be in cases where you only aspirate blood and there is no other cells, a virtually acellular specimen, or others where you have some follicular cells, but they're obscured by blood or by clotting artifact or by drying artifact or some other issues. So what exactly is an unsatisfactory sample? An unsatisfactory sample is a sample or a specimen which fails to meet the adequacy criteria, which brings in the question, what exactly is the adequacy criteria? So the adequacy criteria is as follows. So for a particular sample to be adequate, we need the presence of a minimum of 6 groups of well-visualized follicular cells with at least 10 cells per group, preferably on a single slide. Now, whenever you use a word preferably in something which is like a rule book of guidance, I think it brings in an element of ambiguity. That means it may be on one side, maybe on two sides, so you have to choose something. I choose to use this single slide criteria. So I call something adequate when I have 6 groups of well-visualized follicular cells, of at least 10 groups in a single slide. Now the key word here is well-visualized, which means that it is well-stained, unobstructed, and undistorted. However, as many of us, all of us mostly know, who are in practice, that there are exceptions, and these are really life saviors. First of all, if a specimen has an abundant amount of colloid, okay, then you really do not need these follicular cells. You can just call something benign if you have abundant amount of colloid. If there is inflammations as a result of autoimmune thyroiditis, granulomatous thyroiditis, it can be complete sheets of inflammatory cells, and when you take into consideration the fact that you're in the lesion, the ultrasound findings or other findings, you need not have so many cells and you can still call them as benign. And of course, if you have an aspirate which you have a few cells, but those cells are definitely in your eyes atypical or malignant, and of course, just like any other system of cytology, the sample becomes adequate. But what about cyst fluids? Cyst fluids, irrespective of the presence of histocytes with less than 6 groups of 10 cells, are considered unsatisfactory. So if you have a lot of cyst cells, but you don't have the follicular cells, you call it unsatisfactory. However, there is an issue of abnormal looking cyst cells, and you call it unsatisfactory, and you leave it to the clinician to decide upon the further course of management. So the clinician looks into the cyst, looks into any solid components associated with the cyst, and wants a repeat FNA, we leave it to that. So what are the points to ponder upon? Very interesting. You see, it is known, it's now very well known that 95% of the non-diagnostic samples actually turn out to be benign. If you follow them up and look into it, they turn out to be benign. So various questions have been asked that don't you think that these criteria that we are using of this number of cells, number of clusters, don't you think that this is a little bit too stringent? It might be stringent. In fact, there are certain studies which have lowered the criteria of stringency, and they have still found about 95% of non-diagnostic samples are benign. So they didn't use that criteria which you saw in the previous slide. So does that mean that we should reduce the criteria? It might be reduced, maybe in the future, but at present, we do not have enough of evidence to say so. So till that time comes, the recommendation is that we stick to this criteria that we have, that are there. One question that I often I'm asked is that when exactly do I repeat a thyroid FNA in case of an unsatisfactory specimen? Actually, there is no clear-cut guideline, to be honest. If you wait for too long, it was believed that you wait a little bit too long. If wait long, and if you wait long, then the chances of procedure-induced atypia reduces. There is no such evidence as of now. My personal experience, I use around 3 to 4 weeks, something around 5 to 6 weeks, depending on what I have seen, and ask for ultrasound guidance. Of course, if the initial FNA has been palpation guided, I ask for it as an ultrasound guided FNA, and that is a recommendation. Now, after 2 successive non-diagnostic results, the choices are between close clinical follow-up or go straight for surgery. And this is a part of the clinical decision-making procedure for the clinician to decide. Now, let us see some pics. So, this is colloid. Looks pretty spectacular, but you only have colloid, you don't have anything else. Is this an adequate sample? Of course it is. Here, we have lots of inflammatory cells, no follicular cells. Once again, it is an adequate sample from a case of lymphocytic thyroiditis. How often do you see this? Very, very often. This is a different kind of a problem. This was only one cluster that was seen in the entire smear. How many cells are there? Maybe what, 5, 6, and that was the only cluster. So of course it doesn't fulfill the criteria of cellularity. But can you ignore them? Of course you can't. This is a satisfactory sample because here highly atypical cells are present. So you are going to call it satisfactory. And this actually turns out to be a metastasis from a lung tumor into the thyroid. And so you have, and so that the rule is, the advice is that even when you see a sample which is extremely hemorrhagic and you know it is from a nodule, you should screen the sample very, very carefully because there could be a few cells lurking here and there, sinister-looking cells, and they are going to clinch your diagnosis and make a big difference in the patient management. Now here is a picture of cyst contents only. Of course, this is inadequate. If you don't see anything else, this is inadequate. But this is a pitfall alert. Whenever you see only cyst cells, you might be dealing with something like a cystic variant of a papillary thyroid carcinoma. You'll be seeing a lot of these in the next webinar. But please remember, when you see a lot of cysts in a hemorrhagic aspirate, look at the cyst cells very carefully. You might start finding things like nuclear inclusions in cyst cells and some kind of pallor of the chromatin. So we have to be very careful. So it also has a specific place for it in the AUS category, and we shall talk about it very soon. Other pitfall alerts. Renal thyroiditis can give rise to extremely paucicellular aspirates, but the most important are anaplastic thyroid carcinomas, which are very fibrotic, and they can give rise to absolutely no cells at all, just some blood, a few fibrous tissue, and maybe 1 or 2 atypical looking cells. So please pay attention. Look at what is written in the clinical history. Rapid growth, very fixed the lesions which are fixed to the surroundings, and of course the appearance on imaging. Okay, so be very careful. Even if you call them even if you call it an unsatisfactory sample, it should be at the back of your mind that you might be missing some of these things. Now, this is not the situation. You have lots of follicular cells. Just see the number of follicular cells, maybe hundreds of thousands of follicular cells right here. But what can you do here? You can't do anything because this follicular cell, these cells over here are enmeshed in the blood clot. So, of course, it's going to be an unsatisfactory sample if you don't find any well-visualized cells in other parts of the smear. Here too, there are some follicular cells, not very well smeared, a lot of crushing artifacts, a lot of blood around. So even if the number of follicular cells are quite a lot, apparently, you really have to call it an unsatisfactory sample. So we go into the next diagnostic category, that is benign cytology. So the term benign cytology is consistent. We can use the word benign follicular nodule, which actually includes adenomatoid nodule, colloid nodule, etc. I like to use the word colloid nodule. Or it could be a report of consistent with chronic lymphocytic / Hashimoto's thyroiditis in a proper clinical context. And from what I hear from my colleagues in endocrinology is that they rely a lot nowadays on the clinical picture as well as on the thyroid antibody tests. And many of the cases, they actually do not send the patient for thyroid FNA until they find a specific nodule which they want to interrogate. Of course, there is another one, which is the granulomatous thyroiditis, and there are certain other conditions like black thyroid, etc., which can come under these categories. So this is about, again, for the records, for those of you who are going to come back later on, I would just like to keep a note of these. So these are there. So benign follicular nodules, first of all, usually shows lots and lots of colloid, and colloid has a wide variety of appearances. And it is extremely important to be familiar with those things because colloid is so important. The single most important variable in deciding benign versus malignancy in thyroid FNA would possibly be colloid, because just the moment you see colloid, things totally take a different turn, although there are exceptions. The follicular cells are arranged in monolayered sheets. Please pay attention to this phrase, monolayered sheet. We are going to be hearing more about them a little bit later, with even placement. There could be 3D clusters, right? Tissue fragments, and even papillary hyperplastic fragments. So if you see a papillary fragment, okay, it needn't necessarily be from a papillary thyroid carcinoma. In fact, most of the time that you see a papillary hyperplastic papillary fragment, you're possibly going to see it in benign conditions. So it is very important to know that. Just seeing papillary fragments, no, you have to look for other features like nuclear features. There is minimum amount of overlap and crowding. A small flat sheet without significant overlapping represent macrofollicles and are not exactly microfollicles. You may find microfollicles. They say rare microfollicles, but when you see a lot of macrofollicles and with that you see a pretty good number of microfollicles in the background of colloid, you can just safely call it a colloid nodule. You may come across a number of stripped follicular cells which resemble lymphocytes. You can come across Hürthle cells, more of that a little bit later. The nuclear approximately the size of RBCs, you can see a significant degree of nuclear size alteration. The chromatin is uniform, granular, and has got regular nuclear outlines. And the cells actually contain some fine pigment. I actually picked up a slide, but I forgot to include it in this particular lecture, and represent hemosiderin or lipofuscin. Of course, you can find a cyst macrophage is one of the commonest things, representing colloid goiter with cystic changes. You may even find some repair cells. Look at this collage. Beautiful, isn't it? The colloid can really have a wide variety of appearances, and it can really be very good to look at. And most importantly, when you see so much of colloid, the chances of malignancy goes down significantly, except a particular variant, which I'm going to talk about in the next webinar. This is colloid appearing as clouds. This can be a bit tricky when colloid gets mixed with blood. Okay, so you see the RBCs get a little bit, pushed into each other, and this is the colloid in between. So this is colloid with blood. Sometimes can be a bit tricky. This is inspissated colloid, thick colloid. Inspissated colloid is very important from the angle of the fact that when you don't see any other colloid and you see a papillary carcinoma, you can have this thick little chewing gum colloid, thick bits of colloid, inspissated colloid. But this, of course, is the case of colloid goiter most of the time. Once again, you see inspissated colloid in plain, simple, run-of-the-mill colloid goiter. Inspissated colloid means absolutely nothing unless and until there are other features of papillary thyroid carcinoma, other malignancies. Now this is interesting. This is not colloid. Looks like colloid, but sometimes, you know, your radiologist or somebody might have some butter fingers and drop a bit of, you know, ultrasound gel on the slide and you didn't notice it. And when you smeared it, you know, it gets smeared and this looks like colloid, but this is ultrasound gel material. So to show this thing to you, I just picked up a bit of ultrasound gel and I smeared it on the slide and just stained it. It has kind of a very granular kind of an appearance, although the background has got this definitely has a colloid-like appearance. So if you're not aware of it, you might mistake it as colloid. Inspissated colloid look-alike. One of the inspissated colloid look-alike is amyloid, which is found in the case of medullary thyroid carcinoma. So this is a medullary thyroid carcinoma. This is another medullary thyroid carcinoma. This is inspissated. This is amyloid. This also is most likely is amyloid, and there is, frankly speaking, it's very difficult to differentiate between inspissated colloid and amyloid. Some people may be more confident, but it is very, very difficult. And this, of course, is inspissated colloid in a case of a colloid goiter. Now, this is interesting. Sometimes you have serum, and this serum, it collects only at the edges of the slide near the clots. So this is serum. This is not colloid. So if you see something looks like colloid, but is only present around blood clots, what you are dealing with is not colloid. This is just serums, but it looks very, very similar to colloid. So look at the way it is present. It's very important. Continuing with colloid nodules. So this is a colloid nodule, and you can have very, very large tissue fragments. This is one of the edges of one of the fragments on Caponical You see that how beautiful, nice monolayered sheets they're present in. Some of the cells are just stripping off at the margins, almost forming, not exactly, but almost as if they're trying to form some microfollicles. Again, a colloid goiter, right? A fragment of a macrofollicle possibly, coming up here, a little bit sharp edges, very well monolayered sheets. In some places, there seems to be an overlap, but then these are possibly because of folds which occur at the margin rather than calling them overlap. This once again is a very large fragment, almost having a papillary configuration, which I found in a colloid goiter. This is a monolayered sheet in a colloid goiter. There is one cell which appears to be a little bit large, but not to worry so much. These are some of the stripped nuclei which look like lymphocytes in colloid nodules. Little small little aggregates here, and this again the edge of a big tissue fragment. It's a macrofollicle at the edge of tissue fragments, and here it's a little bit on the low power, but you can see that almost like microfollicles are beginning to form here. Okay, but this really doesn't mean anything, because when it's a lot of colloid and it's just happening, just getting stripped off the macrofollicles, it should not raise any concern. Another macrofollicle in a colloid nodule. This is a colloid nodule with a cystic change. So there's a watery colloid and some cyst cells over here. Sometimes colloid nodules can show some amount of spindle cells, especially in long-standing colloid goiters. And some of the times the cells can look quite nasty, like not exactly here. This is something different. So this is a colloid nodule with Hürthle cells. So you can have a significant number of Hürthle cells in colloid nodules because of the presence of background colloid, just benign, nothing to worry about. Here you have a colloid goiter. You can see the colloid in the background mixed with blood. The cells start looking a little bit juicy. They are a little bit pleomorphic. But once again, this amount of pleomorphism could go with repair cells. Some people may like to use the word atypia in this, but well, I think this is more or less something which can go with a colloid goiter. Next is Graves' disease. Now, important thing, it is usually diagnosed clinically without any need for FN. As I showed you the algorithm or the flow chart in which one of the first things that you do is a TSH. Once you start doing that, you're going to start picking up Graves' disease. And however, Graves' disease occasionally can show cold nodules, and this might prompt a request for FNA. It usually shows variable amounts of colloid. So Graves' disease colloid can be actually quite scanty, which can lead to a little bit of a concern. It can show follicular cells, Hürthle cells, and also can show a bit of lymphocytes. The follicular cells are present in flat sheets and loosely cohesive groups. They do show cytoplasmic vacuolations and anisonucleosis. They may show flame cells. Okay, so fire flame appearance, you're going to see a picture. And in Graves' disease, there is a significant amount of chromatin clearing and intranuclear groups. I suspect that if one does not follow the algorithmic part of not doing FNAs, in cases with features with low TSH where there is a suspicion of Graves' disease, if you start doing FNAs in all those cases, the chances of us giving atypia of undetermined significance is going to increase. So the fact that these lesions are usually not sent to fine needle aspiration cytology, I think is something which is helpful for the cytologists because they can show a wide variety of changes, especially changes at the level of nuclei, right? Some degree of scanty colloid. So it is definitely going to enhance. I'm not aware whether there are any such studies, quite unlikely, but I think that by not aspirating patients with nodules with Graves' disease is very helpful for cytological interpretation, or else our life is going to be far more difficult. So this is from Graves' disease, happened to be Graves' disease, which was aspirated. They're very cellular. As you can see that the fragments, they just have kind of a stag horny outline, starts forming microfollicles, lots of vacuoles, which are very, very helpful, of course. Macrofollicles here, big fragments. And if you go to the next one, this is what you see. See a lot of vacuoles. And here are the fire flares. This is the picture which I took from one of our departmental studies. I can assure there are far better fire flares, but I just couldn't find the good ones when I wanted to take the pictures. This is the fire flare appearance of this magenta colored bits, drops coming out from the surface of the cell. This I found at the Papa-Nicolau image atlas. I'll tell you what exactly is a fire flare appearance. Now, important thing is I do not know what was believed maybe 15, 20, 30 years ago. Fire flare appearance has got nothing to do with the benignancy or malignancy of a lesion. So fire flares can be found in hyperplastic nodules. In general, colloid nodules, they can be found in follicular variant of papillary carcinoma. They can be found in follicular carcinoma or follicular neoplasms, papillary carcinoma. So they really do not help. According to most of the evidence-based large-scale studies, they can be found in all sorts of conditions. So just based on fire flares, don't think that the lesion is malignant or benign. The next in the card is lymphocytic thyroiditis. These are the things included in it: Hashimoto's, subacute, focal lymphocytic thyroiditis. Lymphocytic aggregates can be present in nodular choroid goiter, Graves, and IgG4 related. In Hashimoto's, primarily, we see a diffuse enlargement. However, it is aspirated if there is a development of nodularity or rapid increase in thyroid volume. So if there is a development of nodularity, lesion is aspirated to see if there is a malignancy which is developing on the Hashimoto's, or there is a rapid increase in thyroid volume producing choking sensation. Maybe there has to be some kind of intervention, so an FNA is done before that. And of course, the positive anti-thyroglobulin, anti-microsomal antibodies which are associated with it. So the picture, the Hürthle cells, they usually show a polymorphous population of lymphoid cells. If there is a predominance of Hürthle cell to the extent of sparse or absent lymphoid cell infiltrate, it becomes challenging to rule out a Hürthle cell neoplasm. It has been said that the sizes above 3 centimeters have a higher risk of malignancy. So that's very important. The Hürthle cells actually may show nuclear enlargements, it can show chromatin clearing and grooves. So this should make you raise the threshold to call something suspicious, but if the features are very high, then you can move on to categories 3, 4, or 5, okay, depending on how comfortable you are with these nuclear features. If there is a monomorphic population of lymphoid cells, there is always a suspicion of lymphoma. You can consider submitting the specimen for flow cytometry. We are going to discuss this a little bit detail a little bit later on. So this is the picture of lymphocytic thyroiditis, only almost a full house of lymphoid cells, various stages of maturation. This is a lymphocytic thyroiditis with lymphoid cells infiltrating. Some cells which are possibly Hürthle cells and some may be histiocytes. It becomes difficult. This, of course, is a lymphocytic thyroiditis where lymphocytes are seen to infiltrate the Hürthle cells. And of course, as I have said, that when there is a lymphocytic infiltration of Hürthle cells, there is going to be changes in the nucleus. You see the chromatin is clearing up, and there are grooves. Even inclusions have been described in such cases, but I have not seen too many inclusions in Hashimoto's thyroiditis without it being actually a papillary thyroid carcinoma. So this far is okay. So enlargement of the nuclei opened up chromatin, irregular nuclear outlines, and some degree of suggestion of grooves. So as I've said, you can also have an extensive degree of Hürthle cell proliferation, thereby bringing in the possibility whether you are dealing with a Hürthle cell neoplasm overlying a Hashimoto's thyroiditis. However, that is extremely rare. It is not very common. The commonest tumor that arises in the background of Hashimoto's thyroiditis is papillary thyroid carcinoma. About granulomatous dequervance thyroiditis, these are painful lesions preceded by viral infections, usually show granulomas, multinucleated giant cells, degenerated follicular cells with vacuoles. Early lesions may show neutrophils and eosinophils, and the late stages may actually be hypocellular. So this is important. So these are pictures from granulomatous dequervance thyroiditis. You see this multinucleated giant cells, very dirty kind of a background, the follicular cells showing these vacuoles and various degenerative changes. Some neutrophils are also seen admixed with this infiltrate. So this is very important. You see you may find a very thin, pale, watery colloid too, but the important thing are the presence of these multinucleated giant cells, inflammatory cells, and these degenerative changes in the follicular cells. Usually it's a pretty easy diagnosis. About reduced thyroiditis, I do not have any pictures. They usually produce hard-fixed thyroid mass that clinically resembles anaplastic thyroid carcinoma and lymphoma. So that is a very important thing to keep in mind. They are usually acellular or hypocellular with bland spindle cells if you're lucky, or some collagen fragments. Colloid is absent. Next, the last two categories we shall be dealing with now. First is, this particular category is Atypia of undetermined significance or follicular lesion of undetermined significance. And as the recommendation goes, you should try and choose one of these two, whether it is a follicle predominant lesion or not. For your lab, choose one and stick to that. What is the definition? Now, the definition of atypia of undetermined significance is reserved for specimens that contain cells, which could be follicular, lymphoid, or others, with architectural atypia and or nuclear atypia that is not sufficient to be classified as suspicious for follicular neoplasm, suspicious for malignancy, or malignant. On the other hand, the atypia is more marked than what can be ascribed confidently to benign changes. This is straight from the recommendations of Bethesda. And as I have said, use either AUS or FLUS. The next slide is possibly the most important slide as far as AUS is concerned. You see, these are the general situations where you can call a sample or a specimen AUS or FLUS. It is not a subclassification. So these are the situations where you call this AUS. So first of all, the major groups I would put as the first three I will put in one group, and the next three I'm going to put in another group, just for the sake from the conceptual angle. The first one is cytological atypia. The next one is architectural atypia. And the third one is a combination of cytological and architectural atypia. Right? So this is one particular group. The next one are AUS related to Hürthle cell content. We shall see what this stands for. Then atypia NOS, where you cannot put it in any of the above. And finally, atypia based on lymphoid cells. May sound confusing, very confusing, but when you look at the examples, I think the concepts are going to be clear. So you're going to take this one very slowly. So what exactly do you mean by cytological atypia? When you say cytologic atypia, the cytologic atypia can be either focal or it could be extensive but mild. So what exactly is focal atypia? In a focal atypia, few cells show nuclear enlargement, pale chromatin and irregular nuclear contours. In extensive but mild, many cells show the same thing. So there is no difference from that angle. There is also no difference from the angle of the fact that in neither of them inclusions are allowed. So if you see inclusions, you don't call it AUS. So if you see a case of cytologic atypia focal, there should be no inclusion, right? Even in cytological atypia extensive, no inclusion. So otherwise, in the aspirate should be benign looking, right? So these are the two major facts as far as cytologic atypia is concerned. The cells show some changes, there are no inclusions, and otherwise, if you look at the aspirate, the rest of the aspirate shows absolutely benign changes. The other things which are included in this group are easier to understand. Atypical looking cyst cells and histiocytoid cells. The examples should help you. So what is this? This is AUS because of atypical cells, right? Shall I call it focal or shall I call it extensive? I cannot say by looking at one slide. If I see this in a small area, I call it focal. If I see this in a number of places, we call it extensive. But the important thing over here is to understand why this is atypical. It is atypical because of the following changes. Most important is that there is a significant amount of overlap between the cells. There is some degree of clearing of the chromatin. There is overlap here, and there is some element of nuclear membrane irregularity. So what? A good way of understanding the difference is to compare with another sheet or a little macrofollicle of cells where looking at them side by side. Compare them. Here, there is no overlap. Whatever overlap is possibly towards the edges over here. Okay, so there is no overlap. This is a far better looking monolayered cluster. Nuclear margins are all very regular. Look at the chromatin. It is far denser compared to some of the pale chromatin over here. So this I can safely call benign, but this one is AUS. Right, this is an AUS on IMSA stain. As you can see over here also, there is this little bit of nuclear overlap here, some kind of alteration in the nuclear outlines. Okay, so this again I will call AUS. This is a pretty good AUS. There is a marked nuclear overlap, some amount of chromatin clearing, right? And this nucleus is pretty big. So this one is AUS. AUS because of atypical cells. This we have not gone into the particular category of architectural atypia. When I talk about architectural atypia, I'm talking about microfollicles. We shall see those things later on. This once again, AUS because of atypical cells, because of overlapping, because of some amount of nuclear membrane irregularity. Okay. Chromatin clearing, I usually try not to comment on heme sustain. Once again, AUS because of atypical cells. This is forming like a linear trabeculae of cells with some degree of nuclear irregularity and some chromatin clearing. Now, here it is AUS possibly, but you see a lot of lymphocytes which are admixed. So this is AUS in the background of lymphocytic thyroiditis. When I see this, I usually try and avoid calling it an AUS, and I just ascribe it to the fact that this is because of lymphocytic thyroiditis. So I bring my threshold very high and I don't call it AUS, but some people might. This is a very difficult situation. You have these cells which show a lot of clearing, a lot of irregularity of nuclear outlines. Okay, I can't see any inclusions, but it is all entangled in a clot, and you all know that when you have a little bit of clot and you have some blood admixed, it starts to, because of some kind of a local drying artifacts, it shows you some artifactual changes. So, well, you can use the term AUS and you may add a note somewhere. Now, so that brings us back from AUS, the AUS due to atypical cells, not exactly due to architectural changes. The other thing which comes under AUS is because of AUS due to atypical cyst cells. We know what cyst macrophages looks like, but then once in a while you will come across these cyst macrophages with a slightly more opaque cytoplasm, a little bit, not exactly the bean-shaped nuclei. You may start looking some amount of nuclear clearing, which is not very well visible here in this particular stain. So these are atypical looking cyst cells. The important thing to understand is that if you see atypical looking cyst cells and everything else is fine, you can still put it under the category of AUS. And as I said, without any other abnormalities. So atypical cyst cells belong to AUS. This is another thing, a kind of a variant of atypical looking cyst cell. The term which is used is histiocytoid cells. When you see these cells which has some kind, looks like kind of a mucinous secretion, I'm using it only as a kind of a comparator. This is not mucin. There's some kind of a thick material inside the cell. So these are called histiocytoid cells. This, of course, comes from a case of a papillary thyroid carcinoma. So this is not AUS, okay? You will see this again later on, but just to show you what such a cell, if you just see this cell in isolation in an otherwise benign looking smear, you will call it AUS. This is only for the purpose of representation. Architectural atypia is something where you use it under the following circumstances. It is a scantily cellular specimen with scanty colloid. That is a very key fact, a scanty colloid with rare cluster of follicular cells, almost entirely in microfollicles or crowded 3D groups. So please, this is important, a scantily cellular specimen. So what if we find, or what if we look at a smear where you have the same features, microfollicles, crowded 3D groups, scanty colloid, but the specimen is highly cellular? You will not call it AUS. You are going to call it follicular neoplasm / follicular neoplasm. So that is the major difference. The changes which you see in a follicular neoplasm / suggestive of follicular neoplasm is extensive. The same changes, if you see only in a few cells, few parts of the smear, you call it AUS, and that AUS is conceptually AUS due to architectural atypia. You do not need to write that in your report, AUS due to architectural atypia. You just say AUS, but this is just for the understanding. Or it could also happen in a markedly cellular smear. So there appears to be a bit of a dichotomy. Not really. It could happen in a macrocellular smear where the microfollicles are present, but the overall proportion of microfollicles are not sufficient. They have not given us a number. So there are microfollicles, but most of the cells are macrofollicles, okay? So in those, so you see macrofollicles, everything else looks like benign, but you see a few microfollicles here and there. So you may call those as AUS due to architectural atypia. Typically, this is the situation. One finds a single area in a slide or a single slide which looks different from the rest. an overall mixed but predominantly macrofollicular aspirate should be ideally called benign. So look at this. If I look at this particular area where the entire smear looks like this, I'll possibly go and move into the realms of follicular neoplasm. But in this particular case, this was possibly present in one particular field of or one or two fields. So the most of it was benign looking, and in one area we had these microfollicles. So what do? Do you call it follicular neoplasm? No, you call it AUS. So this is the second major kind of a situation where you call things AUS. Look at this one. On its own, extensively present in most parts of the smear, you would call it possibly a follicular neoplasm, right? In fact, they look pretty ugly from the angle of the cellular morphology. But anyway, we'll deal with those things some other time. But if this is present only in a small part of the smear, only these microfollicles, you are going to call it AUS. If you see in a large part of the smear, many areas of the smear, you are going to call it a follicular neoplasm. Another example. Remember the keyword, it is found focally, only in few areas of the smear. Look at this one. This, of course, is a bit of an architectural atypia, a bit of a watery colloid in the background, which should move you towards benign, but then sometimes even with watery colloid, you see too many of these microfollicles in certain areas. So you might like to be a little bit cautious and put it under the AUS category. And of course, not what I would call an AUS, because you see the architecture, big fragments, and from the edges of the fragment, maybe a few follicles coming up over here, maybe a few more in other places. So this is not what I would call AUS. You see the amount of colloid, and this is happening right at the margin, and you can know that this is just broken off from the macrofollicles. Right. This, of course, is something where it's a combination of both. You have got, again, something happens focally. If this happens extensively, it goes into totally different categories. So focal areas where you have got some kind of architectural atypia, microfollicles, overlapping cells. And I think you can see that there is a bit of quite a significant amount of nuclear clearing. So both from the angle of the nuclear changes that you have discussed before and the architectural changes combined, we might call it AUS. But if something occurs in a much bigger area, a little bit bigger, you may even go on to suspicious, okay? And some people might call it suspicious just based on these features. Right. Next is AUS due to Hürthle cells. AUS due to Hürthle cells can be in sparsely cellular aspirates with scanty amount of colloid comprising almost exclusively of Hürthle cells, or smears moderately to highly cellular and comprise predominantly of Hürthle cells, and yet the clinical background is that of multinodular goiter. So basically you have to assess the amount of colloid, the evidence of an associated autoimmune thyroiditis, and multiplicity of the nodules. So the context is the key. The AUS due to Hürthle cell, I like to look at it from two scenarios, where there are lots of Hürthle cells and where there are very few Hürthle cells. So I'm going to start off with the where there are very few Hürthle cells, which I use the word, a kind of a term, a negative term called non-hypercellular. Okay. So what is this? So this is an aspirate where I did not find any colloid. And at one focus, I just found this cluster of Hürthle cell. What shall I call it? There is no colloid. Remember, there is no colloid. I'm going to call it AUS Hürthle cells. So two requirements for this. Cellularity is low. Amount of colloid is very little. I see mostly blood. And in one area, I see Hürthle cells like this. I call it AUS. This similar, the same slide, I'm not exactly the same slide, in the same particular case, this is from GIMSA. Okay. Blood, no colloid, only a few areas showing Hürthle cells. So remember two keywords, few cells, that means few Hürthle cells, no colloid. Once again, very few cells, and no colloid. This is AUS due to Hürthle cell. This is not AUS. Why it is not AUS? There are very few cells. These cells are Hürthle cells, but there is colloid in the background. So this is not AUS. This is colloid goiter with some Hürthle cells present. So this is going to be benign. Right. So AUS Hürthle versus benign. So AUS Hürthle, colloid is absent. AUS colloid nodular Hürthle cell, of course, colloid is present. So in these cases, the presence of colloid is a key factor. What about hypercellular situation? Now, look at this particular picture. If I told you that this is from a single nodule and the patient has got no other lesion in the thyroid, one single nodule looking like this is going to be a follicular neoplasm / suggestive of follicular neoplasm Hürthle cell type. If I told you that this is a patient who has got a multinodular picture, is that of a multinodular goiter, there are multiple nodules and one of the nodules look like this, I have to use the word AUS due to Hürthle cell content because it is one of the nodules in a multinodular goiter on imaging. Okay. In case of such an aspirate, I would call it a follicular neoplasm. If this was from a solitary nodule, I would call it a follicular neoplasm or SFN, suggestive of follicular neoplasm Hürthle cell type. But I will not do so in this case because I know that this is from a lesion which otherwise looks like a multinodular goiter. So it is a Hürthle cell kind of a hyperplasia in a patient having a multinodular goiter. Once again, similar, AUS due to Hürthle cell content looks very same. If it would have been a solitary nodule, I would have called it follicular neoplasm / suggestive of follicular neoplasm. But this happens to be in the background of multinodular goiter. So I just hold back, I pause a bit, I put it as AUS because this gives the clinician a chance not to go for lobectomy, right? And just hold on and give the patient a chance. Maybe follow him up for a while or follow her up for a while. Numerous Hürthle cell in the background of lymphocytic thyroiditis. Okay, this some people might sometimes start calling it AUS. I usually don't call it AUS because I have a very, very high threshold. I shall not call this AUS, whatever be the rate of proliferation. Although sometimes if you see a size of more than 3 centimeters, it start going on into the other categories. What I am going to do, I'm going to look for areas which show classic features of papillary thyroid carcinoma. If I see those features, then of course I'm going to go into the categories 5 and category 6. That is something different because papillary thyroid carcinomas, the most common carcinomas arising in the background of Hürthle cells. Hyperplasia of Hürthle cells in the background of lymphocytic thyroid is what is the danger of raising the threshold too high? Of course, you have to remember because the commonest malignant tumor is papillary thyroid carcinoma. So one cannot say that every nuclear change that you are seeing is because of reactive changes and there is no papillary carcinoma. No, we have to be realistic in these cases. And of course, we will see one example in the next webinar. There is a variant of papillary thyroid carcinoma with prominent lymphoid aggregate, which is called the Warthin-like variant of papillary thyroid carcinoma, which typically occurs in the background of Hashimoto's. And these are some of the nuclear alterations which you have already seen in the background of lymphocytic thyroiditis. The other thing is atypia NOS, that is, there is no other cause. So this is nuclear enlargement with prominent nucleoli you suggestly see. There is no other suggestion of papillary thyroid carcinoma. The patient has a history of exposure to radioactive iodine or therapy with carbimazole. If this is the situation, you call these things a benign. If you do not have such a situation, you can, if you are not facing such a situation, but this is not the case, then you just call it atypia. And of course, you can have this. You can have samoma bodies somewhere in the smear, no other changes. You can still call it AUS because of samoma bodies if you have no other changes to suggest any other lesion. This is AUS possibly occurring in the case of a long-standing goiter, which I have alluded to before. Okay, it's your pick to call it AUS or to just leave it as benign reactive changes because of reactive changes. But what about this one? This, I think, is a little bit too much. Look at the pleomorphism. Look at the multinucleation, very prominent nucleoli. I would find it extremely difficult to just leave it as benign or just even as AUS. I'd be very uncomfortable even if there is lots, if we find lots of color, because of the fact that anaplastic carcinomas can sometimes lurk and they may just start in the margins of colloid goiter. And therefore, I am going to make a very clear note and call the clinician and tell the clinician, I'm looking at this, you better review your findings and maybe repeat the FNA or do something else about it. You may sometimes see this, sometimes can be very cinematic, the kind of reactive changes, but I am not very comfortable to just call it reactive changes. And of course, there are atypical lymphoid cells leading to AUS, but I have never ever diagnosed an AUS based on atypical lymphoid cells. If I atypical lymphoid cells, if I have with suspicious cytology, I would like to put it in the next category of 5 and not leave it in the category of AUS. So this I'm not going to discuss any further. This is one of the examples of AUS so-called with atypical lymphoid cells. As I said, I would like to put it suspicious of lymphoreticular malignancy. So what are the points to ponder in AUS? You should try and keep your AUS. The recommendation is under 10% of thyroid FNA, and AUS to malignancy ratio should be under 3. The changes which occur as a result of artifacts like clotting should be used to distinguish from those which are actually not. Sorry for the typo. The last one is follicular neoplasms and suspicious of follicular neoplasms. Important. So the most important thing about follicular neoplasms and suspicious neoplasm are two. One is what exactly are the structures called follicles, and the second one is the usual absence of colloid, but not very, very strict. You can still see a little bit of colloid even in follicular neoplasms. We'll deal with that. Aspirates are categorized under this group when they are cellular and they comprise of follicular cells, most of which are arranged in an altered architectural pattern. Architecture is very, very important. Cellularity is very, very important. These two things. I've already said, if it is not very cellular, it is going to be AUS. If it is cellular, it is follicular neoplasm with similar comparative features. This is characterized by significant cell crowding and or microfollicle formation. So what exactly is a microfollicle? A microfollicle is actually, this is important, it's a crowded, flat group of less than 15 follicular cells which are arranged in a circle that is at least 2/3 complete. So this is the definition of microfollicle which you should use. So what are the essential features? First, very important, moderately to markedly cellular sample. Colloid is typically absent or scant, but there could be a little bit of colloid. Formation of microfollicles or ribbons of overlapping cells called trabeculae. There could be some inspissated colloid that is present within the microfollicle. Some cases may show background of colloid and macrofollicles as well as cyst macrophages. So you can see cyst macrophages. You can see a little bit of colloid. We'll see some examples. The nuclei typically are round and hyperchromatic with inconspicuous nucleoli. Once you start seeing nuclei which are a little bit paler, right, would start showing a little bit of chromatin clearing and a little bit of irregularity, it might be dealing with something which is a follicular variant of papillary thyroid carcinoma or NIFTP. But and there are scope of putting some notes, but about those I shall discuss in the next webinar. The nuclei should show classic features of papillary thyroid. If the nuclei show classic features of papillary thyroid carcinoma, focal samoma bodies or true papilla do not ponder or hover at this particular. If you see all features of, if you see the follicles, if you see samoma bodies, if you see true papillae, don't keep it at suggestive of follicular neoplasm, call it straight papillary thyroid carcinoma. You can add a note saying that it could be a follicular variant of papillary thyroid carcinoma. So if you are sure about the nuclear features, you see a lot of inclusions, go straight, pull the trigger, call it a papillary thyroid carcinoma. If the nuclear show features suggestive but not definitive of papillary thyroid carcinoma, okay, you see some features because you know papillary thyroid carcinoma follicular variant usually do not show the usual classical nuclear features. One needs to weigh in the available features to put it either in this group or in the group suspicious for malignancy. These aspects might be from invasive follicular variant of papillary thyroid carcinoma or non-invasive follicular papillary thyroid carcinoma. And as you have said, one of the changes which have come in the second edition of Bethesda is a note mentioning so that these could be the possibilities. Could be tricky. And of course, not to forget the case of parathyroid adenomas. So follicular neoplasm, this is a pap smear which shows some microfollicles here, right? And then some overlap. And here the macrofollicles tend to go into each other and form kind of trabeculae, right? So this is a feature. Lot of cellularity. The amount of colloid is very scanty. So here the diagnosis is follicular neoplasm, suggestive of follicular neoplasm. The nuclei do not show the features of a papillary carcinoma. They do not. Here once again, this is an MGG please see that the amount of colloid is very scanty colloid. And here you see the microfollicles, some of the microfollicles joining with each other, forming little trabeculae here, pretty big trabeculae actually. So this is a case where you should call it a follicular neoplasm or suggestive or suspicious of a follicular neoplasm. Now this one could be a bit tricky. This is clear. This is follicular neoplasm because the amount of colloid is very scanty, goes straight. What about this one? I would again call it a follicular neoplasm, keeping in mind the fact that you may find a little bit of colloid. So, but there is a significant amount of colloid over here. So are you going to call it a follicular neoplasm, or are you going to just go back and call it AUS? I do not know, but I would possibly, even with this amount of colloid, I might call this, I would possibly call it I would call it a follicular neoplasm. And there is so many microfollicles and this joining forming trabeculae, yes, I do so. 1,7 over here seems to be some kind of material in the background, some amount of colloid-like material, but overlapping microfollicles here. It is some kind of trabeculae. Yes, I'll do so. Here, it is coming out of a large tissue fragment with little macrofollicles breaking up. No colloid. That's the key. So 1 second of follicular neoplasm, and here it's a little bit different. What you see over here, you see follicular cells, but you start seeing the nuclei opening up a little bit, but not too much. Little bit. So one moment, I just want to go back. Yeah. So it is just starting to open up a little bit. You might start thinking of putting in the possibilities of going into the next group, possibly. Shall I call it a like suggestive of or suspicious of malignancy, and put in a note about NIFTP or follicular variant of papillary carcinoma? But you might possibly see one more case like this. This is a case which we saw very recently. As you said, that we had number of microfollicles, and then in between you have got kind of a secretory material, but they're all thyroglobulin. We did some immunostains, right? And the stain, they're all thyroglobulin positive, calcitonin was negative. We'll be dealing with the immunostains a little bit later on. Not today, the next webinar. So again, a follicular neoplasm, you can see some inspissated secretion. Now this is something interesting. Please pay attention to the two slides. One is to the left and one to your right. Both of them show a kind of a predominantly follicular pattern, microfollicular pattern. Right, but the key is in the nuclear comparison. If you see the nuclei here, I think they're not exactly the same magnification, but here the nuclei is more hyperchromatic, more uniform, whereas over here it is more opened up chromatin. This one will be something where I would put it in the group of suspicious, and with the possibilities that this could be a follicular variant of papillary carcinoma or NIFTP. If with this I see say inclusions, I can even go, I shall go to something up to malignant and call it malignant follicular variant of possibility follicular variant of papillary thyroid carcinoma. So if I see follicles, microfollicles, and I do not see the nuclear changes which are even suggestive or doesn't raise any concern about papillary thyroid carcinoma, I call it follicular neoplasm. If I see something which raises a bit of a concern with some degree of nuclear pallor, nuclear groove, I know there are some people watching who possibly want this go straight for malignant, I do not know, but if I see this without any inclusions, I pay a lot of regard to inclusions, I'll call it a FBPCA. If I see this with inclusions, right, and if you see some other areas with papillae and other things, I'll go straight for papillary thyroid carcinoma. One should remember that follicular neoplasms can look very much like a poorly differentiated carcinoma of the thyroid. This is a poorly differentiated carcinoma of the thyroid. They look very, very similar. We will be dealing with that in the next webinar. This is the other type of follicular neoplasm, the Hürthle cell type. Never ever forget the context, because I showed you that you can have a tremendous amount of Hürthle cell proliferation in the setting of multinodular goiter and Hashimoto's. Once again, Hürthle cells in a follicular neoplasm, Hürthle cell related. Another picture, couple of pictures from similar lesion. You can see a lot of Hürthle cells. This is MGG, just full of Hürthle cells. But again, the context is very important. Not to forget that there are a number of tumors which come under differential diagnosis: oncocytic papillary thyroid carcinoma of Hürthle cell follicular neoplasms, I mean to say, oncocytic papillary thyroid carcinoma, Hürthle variant papillary thyroid carcinomas, and there could be oncocytic variants of medullary thyroid carcinoma, and even metastatic tumor with oncocytic features should be kept at the back of the mind. Last but not the least, parathyroid adenomas should come into this particular group, and they usually show microfollicles, macrofollicles, overlapping trabeculae of cells present like these fragments, and they look very, very similar to a follicular neoplasm. But if you know the history, which suggests some kinds of hyperhormonal features, and it may help you in suggesting it as a possibility, because otherwise it just looks like a solitary thyroid nodule. So this is what you see, some element of anisonucleosis. The vacuolations are particularly useful sometimes if you see them in mind. And this anisonucleosis and strip nuclei of course helps, and you can put in a possibility that could this be a parathyroid adenoma. But it has to be, it requires support from biochemistry and other clinical features. And if you have parathyroid hormones in your lab, you can use it, or you can stain them with thyroglobulin and you'll find that they're negative. So that might be, and calcitonin negative, I guess. So that's about it. Thank you, and I hope to see you again in thyroid webinar 2. It's been a very long webinar and it has been pretty tiring for all of you, I guess, listen to. With this, I turn it over to Nadeem. And if you have any questions or queries, I'd be happy to answer them. Thank you.
Wonderful. I wish I could give you a standing ovation.
Oh, thank you.
Extraordinarily presented. Yeah, extraordinarily presented. I think I have never heard anybody explaining thyroid FNA so well. And as I told you in the very beginning, as it is understood by this system which we work upon, we don't pay any significance to time, because you need to explain the thing in the correct, and you should take your time to explain. You have done a wonderful job, MRINMAY. I'm so proud of you. And we have a lot of people here. If anybody wants to log in and ask some questions, they can unmute their mic and ask a question directly to Dr. MRINMAY. There are a lot of questions on the YouTube. I would go to that later, but first let us wait for some questions on the people who are right here at the Google Meet. If anybody has any questions, please unmute your mic and ask the question to the expert. You can just press stop presenting so that people can see you.
Yeah, okay, one moment. You are presenting, just so I shall stop presenting.
Stop presenting, yeah.
Yes.
Yeah, there we are. You can see you. Right, great. So if anybody has any questions right here in the Google Meet, they can unmute their mic and ask Dr. MRINMAY directly, please.
Thank you, sir. That was really a wonderful presentation. I have one doubt regarding unsatisfactory sample. If we see colloid and cystic macrophages, but no follicular cells, then we would call it satisfactory, right?
Yeah, that is Dr. Anika Singhal.
Yeah, Anika
Singhal. Yeah, I can see her name. Hi, Dr. Anika Singhal, right?
Yes, sir.
Anika Singhal.
Yeah. Yes, see, as far as this particular, so the recommendation is that if you see abundant amount of colloid, the sample becomes satisfactory. So if you see an abundant amount of colloid and you see some cyst macrophages, it becomes a satisfactory sample. That's the that is the way we deal with it. So colloid is extremely important. However, one needs to be very careful about something which I have seen in our practice, that when you are aspirating some amount of cyst fluid, the fluid in the background can be sometimes be very difficult to distinguish from the thick colloid that we expect to see in a colloid nodule. Okay, so I really rely a lot on some amount of thick colloid if you see in the background, and it thickens up more if you do a cytospin. So it helps in the direct smears, although the number of follicular cells are, the cyst cells are less. Okay, the actual colloid on a direct smear tends to become nice and inspissated in little fragments. So that's very useful.
Yes.
It also
So
depends on the kind of attitude which you have, because as I've shown you in one of the slides, the criteria, the adequacy criteria on thyroid FNA is extremely stringent, and many people have questioned that whether we really need to be that stringent and increase the number of unsatisfactory smear, putting the patient through another FNA. I tend, whenever I get a chance of not repeating the FNA, I always try and go for that particular option.
Okay, sir. Thank you. Thank you, sir.
You're welcome.
Anybody else would like to ask a question here? Or should I go to the YouTube questions, please?
Yeah, why not?
Yeah, I think I would go to the YouTube questions. Please try to understand. There is a 5-second lag between what I speak here and what the YouTube people are listening to. So we will wait for some time before we close in from the YouTube. So the questions are few. First, Dr. Nabanita Das. She first says, thanks for colloid look-alikes. That was very wonderful. The look-alikes of colloid, that was so good of you. Then the question which Dr. Nabanita Das is asking is, in TBS new, how these two phrases, follicular neoplasm and suspicious of follicular neoplasm for category 4, because the thought process and judgment will be different for the conclusions. Your opinion, sir?
Yes, as far as okay, can I answer now, Nadeem?
Yeah, please go ahead. And after you finish, just wait for a minute.
Okay, so I understand that these two phrases used alternatively is pretty confusing, because it seems that when somebody is sure about a particular lesion being follicular neoplasm, he or she writes it as follicular neoplasm, and then the person is not sure about follicular neoplasm, he writes suspicious of follicular neoplasm. Actually, this is not the case. These terms, weird as it may sound, are they mean the same thing as far as Bethesda category of this particular Bethesda category 4 is concerned. The fact of the matter is that you should use either follicular neoplasm or suggestive of follicular neoplasm. The way out of the confusion is that at the end of the day, it is the clinician who are reading your reports. So you should have a conversation with your clinical colleagues and tell them that this is what I mean by this. Anyway, you see, thyroid FNA is a particular discipline, like many other disciplines in pathology, which requires a close coordination between the endocrinologist/clinician, the cytopathologist, and of course the radiologist, right? So you should have close clinical coordination. Maybe in institutes you should have clinical meets, and your particular phrases that you use should be clear to them. As far as our hospital is concerned, many of the times, for example, some time back when we introduced this, we have been using almost for 10 years, but I think about a few years back, we introduced the Paris system of classification. So we made it a point to meet the urologist and tell them that what is the significance of the various terms which you are using, although they should be aware of it. So I guess that for thyroid FNAs, when you are using these terms, you should tell them that whatever I'm using, this is what I mean. You should know, because for the clinician, the important thing is what is to be done afterward. They should have, so the management for patients is the same, whether you're using the term FN or suspicious for FN, it means the same thing. So it is the same category, and the risk of malignancy is the same. Yeah, so that's, does that answer your question? Or I mean, I hope, I'm okay, she's not on it.
I think it does. It's so clear. You have made it very clear. And I will wait for her comment. But in the meantime, there was another question by Dr. Nabanita Das, but I think that was a question which was in the process when you were trying to discuss category 3. And I'll just read out the question, but you have answered that question in the entire lecture. So the question which was tricky in category 3 and 4, please give tips to be precise and avoid pitfalls as far as possible. And you have given enough tips and you have shown wonderful photographs for everybody to understand how to put which in category 3 and which one to put in category 4, whether it is the cytological part or the architectural part. I think that job has been very nicely done, and I don't think so you need to get to that furthermore. Another question which Dr. Nabanita Das has asked was, as nuclear inclusions are so crucial, kindly define its cytomorphology and differentiate it from pseudo or artifactual inclusions.
Okay, that's that's a very, very valid point. In this particular webinar, for obvious reasons, because I was dealing with the first 4 categories, I do not have any specific pictures of, I didn't show any pictures of nuclear inclusion, but you are going to see lots and lots of nuclear inclusions if you come back for the next webinar. And I guess that is the webinar in which I am going to discuss the different, stuff which can look like inclusions, which are not inclusions. But thanks for this question, because I'll make sure that I include that in my set of slides. I'll try and include things which the issue of nuclear inclusions. Yes, I'll do so. But that will be for the next webinar. That is for categories 4 and categories 5 and 6. Yeah, I'll do so.
Right. The last is another comment by Dr. Nabanita Das. I would just read that out to you before we conclude. She says, very inclusive content, lucid language, and wonderful delivery. Can listen again and again. I second Dr. Nadeem sir. Standing applause. I wish.
Thank you very much.
A wonderful presentation, Dr. MRINMAY. Very, very, very well done. And I'm sure everybody is going to listen to this again and again. This is going to be, there on the YouTube, and people from Europe and America, as well as East Asia, they would be seeing all this tonight. And we will be getting comments on this in our YouTube channel. And if there is any queries on that, we will definitely put it up to you. You can answer that on the Telegram group, or maybe take it up in the next lecture.
Yes.
I think there are no questions anymore, and I would like to, you must be very tired as well, and I would like to thank you again. Wonderful job, Dr. MRINMAY, excellently presented. See you soon with the next session. Thank you so much.
Thank you,
Dr. Nabanita Das had made a last comment. All question is answered. Anybody would like to make a comment? Yeah, anybody? Yeah, in the group? No, I think there are none, so I think we will call it. Good night, take care, bye-bye.
Thank you, Nadeem. Thanks a lot. Good night.
Bye.
Bye-bye.
Thank you, sir.